opportunity for all of us to celebrate the wonderful things that have gone on over the 23-24 year, to celebrate a number of members of staff, which we'll come on to later, and also to be aware that although this year has been a year of remarkable success for the Trust, as Glenn and others will mention, we are operating in probably the most difficult situation the NHS has ever experienced. And so to members of the public or families who have experienced longer waits than would traditionally be the case with Swift, we apologise, but the one thing I can assure you, and I think today will show you once again, is our frontline teams are quite extraordinary in the efforts they go to and the successes they have to provide the very best care we can. This meeting is a Teams meeting, so in terms of etiquette, if you're not a presenter, could I ask you to turn your camera off and to make sure you're on mute, please? Sarah, could I ask you to start to record the meeting for me, please? Questions can be asked under item 11 or throughout the meeting via the chat box function. And if for any reason you're not able to ask a question under item 11 or through the chat box function after this meeting, you're very welcome to reach out to us and we'll answer any question that you have. Can I just ask again, if you are not presenting, could I ask you to turn your cameras off for me, please? So we have apologies for absence from the meeting. So Sarah Collette, could you please read out the apologies for absence? Thank you.
Thank you. So apologies from governors are Julie Bow, David G, Sharon Ayleswood, Mike Flaxman, Kelly Harrison, Jane Knight, Mary Malloy, Graham Nuttall and Jim Sinnott. Board member apologies are Sophie Gilks, Phil Gilbert, Pramjit Gill and Zoe Mayhew.
Thank you very much, Sarah. So the meeting is going to be divided into 3 sections. The first is the formal stuff, which will be discussion around the annual report and accounts and the numbers. We will then have the opportunity for members of the public to ask questions. We're then celebrating a number of our frontline teams. Every month, us as the board have the Going the Extra Mile Awards, but every year we celebrate the individual Going the Extra Mile annual award winner and the team award winner. And then we have a presentation on prevention, which Duncan Vernon and colleagues are going to present for us. So without further ado, we will go on to the annual report summary for the year ahead. Glenn, over to you.
Thank you very much, Chairman. So I'm just going to share my screen, which I'll look to you, Chairman, if you want to put your thumb up, if you can see that. Good stuff.
That's perfect, Glenn. Thank you.
Thank you. So,
just Glenn, before you get going,
yeah.
Elizabeth, could I ask you to turn your camera off? Thank you very much. Glenn, back with you.
Thank you, Chairman. So welcome, everyone. I can't believe this is actually the 15th annual general meeting of us as a foundation trust. Actually, I've done 18 of these if you count the 3 years that we weren't a foundation trust, but time has flown by. And every year it seems like we've had an even better year than the previous. So I'm going to talk you through some of the headlines of the last year. This summary document is available on our website, as is the full annual report, and I would encourage people, if they have a moment, to look through the full annual reports. There's lots of further information. They're a very open and transparent organisation, so everything is in there. And some of the things I'll go through with you in a moment are some of the statutory responsibilities and targets, but also some of the improvements and developments that we've seen over the last year. So I'm going to start by having a look at some of the national performance targets. And probably before I do that, it would be well worth putting this into context. The reference the Chairman's made already to still in a recovery mode as an NHS post-COVID is that many of the national constitutional standards have not been met by the NHS actually prior to COVID, and subsequently they've deteriorated. So you may well also have heard Lord Darcy produced a report 2 or 3 weeks ago now on which was called an investigation into the performance of the NHS, looked at some of the backdrop issues associated with those performance standards, and helpfully the NHS is now pulling together a long-term plan to get back to delivering those constitutional standards. So as I go through these, I'll give you a little bit of a commentary on where we are against them. Firstly, there's an 18-week standard for referral to treatment time. That's for elective patients from the time they're referred by their GP to their treatment. We saw an improvement on this over the last year, 64% against that standard. We are one of the better performing trusts against that standard. We've got 1 or 2 challenging areas, orthodontics being one of them, and we're working that through at the moment. Other than that particular area, we are meeting the maximum waiting time standards. There's then the A&E maximum waiting time of 4 hours, so a 95% standard against 4 hours. Our 74.6% was one of the best in the NHS. And in fact, our March position, 82%, put us in the top 10 trusts nationally, but also in the top 10 most improved. As a consequence of both of those, we received a capital incentive of £4 million in total, which was really helpful towards some of the developments, which I'll talk about in a moment. Cancer waiting time to urgent referrals from GP, 62-day treatment standard. Again, that's improved year on year, up to a 70.9% performance. Again, one of the better performing trusts in the NHS. Against the screening referral standard, 62.1%. And then moving on to diagnostic waiting time, so a standard of 99% within 6 weeks, we delivered 70.2. And against the cancer 2-week standard, a 62.3% performance. Actually bettered the national standard for symptomatic breast patients, and also bettered the new 28-day referral to diagnosis standard for cancer patients. So it's good to see our cancer performance coming back up to where it needs to be. And then outpatient appointments booked within 3 weeks in advance, just under 78% against an 80% standard. One of the main reasons why our performance is better than your average organisation is that our staff are hugely engaged in what we set out to do, and developing our organisation and innovating. And we're very proud of our staff survey results. So what you see here is an overview of the people promises in the staff survey. Again, South Warwickshire FT came in the top 5 nationally of trusts in terms of what our staff said about us as an employer, as an organisation. And all of that actually correlates to the overall performance, and more importantly, the patient experience. One thing that's not in these slides is the recent CQC inpatient survey, which placed the trust 3rd nationally in terms of patient experience. Some of the key developments over the last year, so there's quite a lot to go through here. I'll do them as quickly as I can. The maternity service received a inspection by the Care Quality Commission. They inspected every maternity unit in the country. And many actually saw a deterioration in their performance rating. We saw a further increase in ours, an overall rating of good, but it was really nice to see the well-led element move from good to outstanding. And that further underpins the overall rating of the organisation, which is still outstanding rated for the trust. Our community recovery service was a pilot that was supported nationally, which is about discharging patients home. That has helped to improve flow and helped to contribute towards that improved A&E performance I referenced. We've also been promoting our home first approach, and this was again something that Lord Darcy highlighted in his review of the NHS, is something that the NHS needs to be more proactive on. As you can see there, some of the communications teams work to promote There's No Place Like Home, recognising the fact that getting people home is the best safety solution for them once their acute episode is over. We've also seen further developments in our urgent community response. So this is admission avoidance activity. We've developed some innovative work with West Midlands Ambulance Service called Call Before Convey, which ensures that only those patients who need to be in the acute setting are brought to the acute setting. Lots of other patients are now getting services taken to them in their home. It's been great to see a further investment in our paediatric services. So one thing to start here is to appreciate the work of our volunteers and our charity. And so we were really lucky that we were able to put some more charitable funding into improving the facilities around our McGregor Children's Ward, which was opened by Joseph Froggatt and his mum Lucy in December of last year. Frailty service is renowned across the NHS actually for innovation and being one of the most effective models. In fact, the National Chief Exec often talks about her visit to our frailty service a year or so ago. They were put forward for a parliamentary award and won both the regional and, more importantly, the national award for their excellence in urgent and emergency care. So well done to that team. We've also been innovating in our surgical areas, and the Da Vinci surgical robot was commissioned and started delivering activities during the year, which has been a great advancement in quality and outcomes for our patients. We are also moving forward on a number of capital developments at the moment, and I'll talk through those now. So Community Diagnostic Centre, anyone who's visited the Stratford site recently will know that there's a lot of building work going on there. We secured some national funding, some community infrastructure levy funding went alongside that, and in the spring of next year we'll be opening a single-storey facility with 2 MR and 1 CT scanner, which will further increase our capacity to diagnose patients, and importantly for those patients living closer to Stratford, that's on the doorstep, freeing up capacity here at Warwick, where I'm sat today, to provide more care locally for those patients in that part of the patch. We've also now opened a new health centre in Lillington, which is a great collaborative project between us and primary care. And anyone who's visited the Warwick site will see right now there's a huge crane on the site moving in our elective hub, which will open next summer. That will be, as well as enhancing the capacity for our surgical services, it will provide what will be the very first proper front door in the hospital, and will improve the experience for patients and staff as a consequence. I'm just going to talk through some of the objectives for the last year. So we always set up a stretch list of objectives which we develop in collaboration with our governors, who we really welcome their contribution, focus on things that matter to our patients. We self-assess against those, so you can see a lot of these are green. I'm just going to emphasise as I talk through it some that relate to the 4 big moves in our strategy that we've set out across the group. And it's probably a good point to reference the fact that we are in a group model with George Eliot in Warwickshire North, with Wye Valley in Herefordshire, and in the last year Worcestershire Acute joined the group. That brings 4 great trusts together and some fantastic teams. What it allows us to do is to look at some of the challenges we face and to share best practice and to implement the best practice across the group. We meet on a quarterly basis at 4 boards, and we often look at these progress towards the big moves. And one of those big moves is about being a very flexible employer. That's borne out in the staff survey results, but as you can see here, a number of other things have gone on during the course of the year which have hopefully improved our recruitment and retention. In fact, that's also reflected in a reduction in agency usage. Our domiciliary care offer has also been enhanced. That's another big move, and a shift to more home-based care has been a feature of our plans over the last year. Prevention is something that you'll hear about a little bit more with Duncan Vernon and colleagues in a moment, but we've been trying to embed in prevention in every single service that we deliver. Again, that was picked up by Darcy, and you can see here some further improvements in that. We've amber rated one of them because we've still got some more work to do there. The final one on that page is about our green plan and our move to be carbon neutral. Again, that's another big move in our strategy. So we want to lead the NHS on reducing our carbon footprint. I won't go through all of the other elements within those objectives, but those are there for people to take a look through. The one area that's rated red is the progress of implementation of our electronic patient record. That was delayed somewhat last year. Colleagues at UHCW were implementing this system first. There was a bit of a delay in that, but that's now been implemented. And we've now signed a contract to implement this Cerner system at both South Warwickshire and George Eliot in around 18 months' time. There is then research, and I'm now going to move to a very quick financial performance overview because Kim, our finance director, will talk about this a little bit more. But in summary, we met our financial targets as an organisation, and as you can see there, the analysis of what we spend our money on, which is mainly our staff, but then also where our money comes from. The interesting part of that would be if you look at the reddish part of that pie chart, we're seeing an increasing amount of activity coming into South Warwickshire from out of area, from Birmingham, particularly from Solihull. Whilst that's been helpful in terms of bringing in income, it does cause us quite a capacity challenge from time to time. So we'll be seeking to negotiate some additional income to support that moving forward. And then finally, some activity numbers. I won't read them all out, but as you can see here, if you look at A&E attendances, you look at the 3-year trend, it's a 16.7% increase in A&E attendances, a 20% increase in ambulatory first attendances. By ambulatory, we mean patients that are seen as urgent care, but not admitted to a hospital bed, treated on the same day and discharged home. And helpfully also some improvements in our productivity around outpatients. So fewer follow-up outpatients, but more first outpatient attendances. So there's about 1.5 million contacts per annum going on. If you ignore births, which involves several contacts, that's a huge amount of activity to support our community. So 2 things just to leave you with on that. Firstly, those activity volumes, when compared to the changes in our workforce over the past few years, show that South Warwickshire is one of only 7 acute providers in the whole of the country that have shown a productivity improvement over the last 3 years. So well done to the teams for doing that. And that and all the other things that I've talked about has also led to the Trust being shortlisted by the Health Service Journal for being Trust of the Year for last year. I hope that we win that, but even if we don't, it's been a fantastic year. And I'd like to take the opportunity to thank all of the staff and the executive team who work alongside me, particularly Adam as Managing Director, who leads the organisation on a day-to-day basis.
Thank you very much, Glenn. So without further ado, I think we are able to move over to Kim Lee, giving us a little bit more detail on the annual accounts and the financial performance review. Kim, over to you. Kim, I think you're on mute.
I was unmuted then, sorry. Hopefully you can see my slides. So Glenn's obviously highlighted a couple of things. I think the key thing really is to articulate that we did deliver a £17,000 surplus. And the key thing is that we met our statutory duty. And I think that's really important for us. Like Glenn, I've been in the organisation for a while and we've had a good track record, but it is a really tough financial environment that we're working in. And in order to deliver all of the really positive things that Glenn's articulated, but also deliver the money, I think, it just shows how we work very much together on this as an organisation. The accounts are consolidated. So what that means is our wholly owned subsidiary, Swift CS accounts, get subsumed into our figures. And any sort of debts or sort of creditors or anything like that are between the 2 organisations effectively get netted out. So the accounts that I present to you include the performance really of our wholly owned subsidiary. Glenn's already shared some of this in terms of slides. So we're already, you know, in terms of our total income, we're a £466 million organisation, and that has grown year on year as we've articulated. But the bulk of that income that we get is obviously for patient-related services, and you'll see from the pie chart that the majority of the money comes via Coventry and Warwickshire Integrated Care Board, and that's obviously an allocation that comes down from the Department of Health and Social Care. And then you also see that we get income from other organisations as well, including local authorities for certain contracts, specifically health visitors. In terms of what we do with the money, we spend it on obviously both pay and non-pay items. Majority is 65% is pay, and we've been consistent around spending 65% really of our expenditure on pay, and that's a metric that we keep a close eye on really as well. And you'll see the breakdown really as well of the rest, but it's, you know, we're a service organisation, and you know, bulk of it is spent on pay. This one here is £30 million capital expenditure for last year. I've just highlighted the key schemes that were over £1 million there for your information. This is a statement of comprehensive income. So this is obviously the accounting speak, right? So this is a table that shows you what income we're getting in total, what we spend on a day-to-day basis, and it compares it to our performance in the last financial year. You'll see references to numbers that you may as a layperson struggle to understand, but we've got we earn interest obviously if we have cash, just like anybody else, in terms of your own personal bank accounts. We have finance expenses, so we pay for interest payable for loans that we might have. One of the big loans that we still have outstanding is to do with Stratford that we've years ago that we borrowed to build, so we pay interest on that. Public dividend capital, the way that I can describe that in layman's terms, is effectively the interest element of a mortgage that you'll be paying. So we're not obliged to pay the actual principal element, but we do have to pay an interest element of the original assets that we as an NHS organisation have own effectively. And the PDC dividend payable is effectively like an interest element, right? So I thought it's useful just to explain that. You'll also see there a share of profit from Innovate. So Innovate is a joint venture company, so slightly different from the wholly owned subsidiary, but we get a profit share from that organisation, and we recognise that in our accounts. And then there's some technical adjustments around how we treat the impairment of assets, and also how we remove capital grants and donations, which would have been included in the income line, and specifically the grants related to Salix grants that we were awarded to support our decarbonisation programme. And then that's how we get to the controlled total surplus of the £17,000. The final statement is the statement of financial position. For those of us who've been around a while, that's a balance sheet. So this effectively is a statement of everything that we own, everything that we owe, and everything that's owed to us, and what our cash balance is in terms of what pocket. So at any point in time, we obviously look at it at the end of the financial year, which is the end of March. What is our what is it that we own, and our statement of liabilities, and that's obviously there for your information. That's it for me. Happy to take questions.
Okay, Kim, we'll come back to questions a bit later, but if anyone has any questions, please pop them in the chat box. So thank you, Glenn and Kim. So just in terms of the formal aspects of the board meeting, we have the minutes of the last year 14th annual Council of Governors and Members meeting of the South Warwickshire University NHS Foundation Trust, which was held on the 21st of September 23. If any members of the board or council of governors had any points of accuracy on those? Could you please raise a digital hand for me now, please? I can't see any digital hands raised. So if you are not happy to approve those minutes as an accurate record and allow me to sign them on your behalf, again, could I ask you to raise a digital hand? Those minutes are duly approved. Thank you. So we'll then move on to the approval of the annual report and accounts, including the quality report and auditor statement. We've had the presentation on this from Glenn and Kim, and which touched on all the quality issues as well. So can I ask Simon Page to propose the acceptance of the annual report and accounts, please?
Thank you, Russell. I'm very happy to propose the acceptance of the accounts and the annual report.
Thank you. And could I ask Sue Whelan Tracy to second those, please?
Yes, happy to second those, Russell.
Thank you, Sue. So with that, if you're not happy to approve the annual report and accounts, again, could I ask you to raise a digital hand? Okay, duly approved. Thank you very much. We'll then move on to the annual report of the Council of Governors for last year. Now, for members of the public, the Council of Governors is a group of mainly elected, but also some stakeholder and staff governors who give up substantial amounts of their own time to support the board of directors in ways that Glenn has outlined on strategy work, but also work with a number of our subcommittees and development work. And so before I go further on, I just want to thank my governors for their enormous commitment to the trust and the citizens that we serve. Members of the public, we are very fortunate to have the governors that we have. I'd particularly like to call out to my staff governors. As Glenn has indicated, the last couple of years have been extremely busy for everyone. And for the staff governors, giving up their time to support the Council of Governors is particularly noteworthy. And I'd also like to thank Mike Wells, who took over as a lead governor during the year from Mary Malloy, who'd kindly supported us in that role for a period of time. So in terms of the summary of the annual report of the Council of Governors, which I chair, the Council of Governors obviously received the annual report for last year. There have been a series of Council of Governors meetings over the last year. We have those every 3 months. And at each meeting, the Council of Governors has received reports on the performance of the Trust and on the Trust's plans and the opportunity to invite questions from its chief officers. We also have the General Purposes Council, which has met regularly, which oversees the work of the Council of Governors, and the Nominations and Remuneration Committee, as well as the Patient Committee and Member and Engagement Committee. So in performing its statutory duties over the last year, the Council of Governors has received and approved the annual review of the board standing orders. They have approved the appointment of the Trust Chair and non-executive directors on their cycle of renewal of Yasmin Becker and David Spraggett. They approved the appointment of Oliver Koffler, Bharti Patel and Oliver Hisco as associate non-executives of the Trust during 23-24. They appointed Mike Wells, the public governor for East Stratford, as the lead governor. They received and noted the annual report from the lead governor. They received and noted the annual self-assessment of the Council of Governors. They received a report from the Trust's external auditors on the outcome of their work as external auditors for that year. And they received the Register of Governor and Governor's interests. Moreover, they considered and agreed amendments to the Council of Governors Subcommittee's terms of reference, and through the Nominations and Remuneration Committee report, received the outcome of the Non-Executive Director and Chair's annual appraisals. And they also received and noted the annual report, quality report, and accounts for the prior year. There have been a series of highlights of work of the Council of Governors during the year in question. In particular, again, as Glenn indicated, governors do have an important role to play in helping us develop the strategy of the Trust, its key priorities, and to make sure that we are doing what we aim to do as a Board of Directors and as a Trust. They've sought assurance on a number of issues regarding consultant and junior doctor industrial action, which was obviously a real concern and has been a real concern, and even now is a concern with our primary care colleagues. They asked for clarification on our haematology services and cancer services, which are offered with our tertiary partners. They continue to contribute to a variety of internal project meetings and working groups to advance and monitor progress of key projects, including our end-of-life care work, our Ellen Badger Hospital redevelopment, our falls prevention work. And again, I'd like to have a shout out to David G, who isn't on the line, for his continued commitment to that work. Our elective hub project, our wayfinding project to try and make it easier, particularly once we've invested in that elective care hub to find it more navigable as a trust, because we do know how easy it is to get lost. And they were also invited to join the Patient Experience Group, the Patient Safety Surveillance Committee, the Medication Safety and Optimisation Committee, the Radiation Protection Committee, and the Serious Incident Review Group, as well as being involved in patient letters and our work in a whole variety of other areas. So you can see that in terms of activity, we do get substantial value for money, so to speak, given they offer their time free of charge from our governors, but they do contribute to making sure that the public interest is upheld in us as a foundation trust. There have been certain elections and appointments. There were no resignations received from public governors during the year, but there was one resignation was received from Roger Waddell, staff governor, for clinical support, which meant there were 2 vacancies to the long-standing vacancy that we've had in that area. In terms of appointed governors, there were nominations following the local elections on the 4th of May, and that led to some changes of the 2 appointed governors to the local authorities. And so we were delighted that Councillor Liz Coles was nominated by Stratford District Council, and Councillor James Sinnott, known as Jim, was nominated by Warwick District Council. So we are very appreciative of your support to us. In terms of comments from the Council of Governors, I'll just read out what was written and agreed with the lead governor. The Council of Governors sees its role as holding the non-executives to account, seeking assurance of quality of care on behalf of patients, and supporting the Trust in ensuring the current position is maintained and, where possible, improved, whilst being conversant of the increased demand, increased pressures, staffing issues and challenges facing the NHS locally and nationally. The Council of Governors, based on information and data available, is assured that the Trust has indeed again performed well this year. Governors are aware that the Trust has not been able to perform as well as in the past against some targets. The Governors acknowledge the challenging times and are assured that the Trust is aware of the areas where improvement is needed and are working to improve the situation when it is in their gift to do so. The Governors are assured that the care provided by the Trust continues to be safe and of a good standard. Led by the Chair and Chief Executive, we expect this to continue. The governors are also assured that the Trust's finances are well managed and the quality of care is overseen by a competent and robust management team and management processes. The governors are also assured that the Trust's ambitious capital programme is well managed and is positioning the Trust to continue to offer the improving care into the future. The governors continue to be pleased to see further developments, innovations, and other changes which support improvements in patient care and patient experience. The Council of Governors wishes to thank staff for their continued hard work and dedication during another challenging year. And again, as Chair of the Council of Governors and Chairman of the Board, I would like to thank the Governors. So that represents the annual report of the Council of Governors. And can I just confirm by a raise of hands, if you're not happy to formally receive and note that annual report of the Council of Governors, could I ask members of the Council of Governors to raise a digital hand, please? Can't see any digital hands raised, and therefore that will be accepted as approval. So we are running a few minutes late, and in my normal fashion, that is the way I tend to run and chair meetings, but I've been told I'm not allowed to do that today. So I'm going to pull forward some comments I wanted to make under any other business before we go to the next stage of the meeting and celebrating colleagues for the Going the Extra Mile Awards. And I wanted to say under any other business, a few thank yous. My first thank you is to Glenn Burley for his leadership as our CEO. We are incredibly lucky that Glenn has been the CEO of Swift for what seems like an inordinate amount of time, but as Glenn has indicated, 18 years. Glenn, in my experience, and we've worked together now for 10 years, Glenn is an exceptional chief executive, and not only are we lucky to have his input at Swift, but also across the Midlands with our role in the foundation group. But his influence at national levels is something that ensures that our voice is heard as the Warwickshire citizenship, and in particular, our belief in the importance of flow management and communities is emphasised. So Glenn, thank you very much. I also want to thank all of our execs and non-execs. The work of the board of directors is very burdensome. Often our board papers run on to over 300 pages every month. But the quality of work done by our execs in leading our organisation and our non-execs in supporting them is immense. I particularly want to have a shout out to two non-execs, and that's Simon Page as my deputy chair and Sue Whelan-Tracy for continued support of our health and wellbeing activities and our work with our BAME and other networks throughout the organisation. Thank you. In terms of our execs, I want to particularly thank two execs. Glenn has indicated the enormous operational pressure we have been on and challenged by over the last year. And so I want to thank Harkamel for her work as our Chief Operating Officer in ensuring that we've been able to perform with her colleagues as well as we've been able. But also, it's difficult unless you visited the site recently over the last year to envisage the level of change which is going on our site. And I know that has been immensely frustrating in terms of car parking for members of the public and staff. But I do want to thank Sophie and the estates team for their quite extraordinary work in getting this court to fit into a pint pot and to get all the moving parts to come together, departments to move, facilities to be upgraded, but also the organisation to continue to be running as effectively as it is. So Sophie and the estates team, thank you very much. I also want to thank all of our frontline staff who 24 hours a day, 365 days a year, do their very best to serve the people of Warwickshire. As I said in my introduction, and Glenn indicated in his slides, we do still fail to achieve a number of our historic standards, but that's not for the want of trying, and it's not for the want of our frontline teams going beyond the extra yard. In particular, I want to thank our emergency department and all for their innovation and ingenuity to cope with the exceptional daily demand challenges they have. Our emergency department is rightly recognised as one of the best in the Midlands, but that comes with its own challenges as people choose to visit us and go elsewhere. And we have over the last a year and a half suffered from the challenges of ambulances coming to us, which should be going to other emergency departments. So to Rachel and everyone on the front line in our emergency department, thank you very much. Also want to thank our governors, as I mentioned earlier, who represent you as members of the public and help the hospital and community teams do their very best. I want to thank our volunteers, our patient forum, our chaplaincy team, and a league of friends who give up their time to help us, to help you. And finally, I want to thank one individual in particular who is retiring at the end of this month, and that's our Chief Medical Officer, Charles Ashton. Charles, you are a wonderful man. Your humanity and civility and professionalism is something that has been a guiding spirit for a number of the discussions we have had around the board table. You will be immensely missed, but I know your presence in Bhaskar and all of the senior clinical team is a legacy which you can be rightly proud of. So enjoy your retirement, my friend. We look forward to seeing many further examples of your photographic prowess made available on social media. But thank you on behalf of everyone in Warwickshire for the leadership you've provided. So I will probably still be told off for running too early, but the date of the next, is there any other business from members of the Council of Governors or board members? Would you care to raise a digital hand? Okay, well, the date of the next meeting will be at a similar time next year, but will be arranged and advertised in due course. So I think we can bring to a close the formal part of the meeting. Can I just ask Sue or Sarah whether we know whether we've got Marina on the call? Because I know there was some question as to whether Marina was going to be able to join us.
No, Marina's not been able to join us, but I noticed that some representatives from the volunteering team are here.
Okay, well, without further ado, then I will lead us to go on to the Going the Extra Mile Awards. So every month, as I mentioned, we call out teams who have gone the extra mile and individuals who have gone the extra mile. And then with the wisdom of Solomon, we need to call out an annual award winner for an individual and an annual award winner for a team. So our annual award winner for the individual award goes to Maria Graham, who's one of our clinical support workers at Ceru. And Ceru, which is obviously over at Leamington Spa, is a quite remarkable facility, staffed by quite remarkable staff, helping members of the public and families in often the most tragic and difficult of circumstances. But Marina won the individual award for Spring 24 after being nominated 5 separate times for Going the Extra Mile award in one quarter. And I'll read out just some of the nominations. One nomination said, she has a patient-centered and holistic approach, meaning that she initiates and encourages patients engaging in a wide range of activities. This includes things as simple as making their own bed, to taking them to the local cafe, if appropriate, based on a risk assessment, to supporting and leading small group activities. The whole multidisciplinary team comments on how invaluable Marina is. We often say, if only we could duplicate her. Another nominator said, I've worked with Marina for many, many years, and she's constantly and consistently going the extra mile for our patients. She embodies all of the Trust's values: safety, trustworthiness, compassion, inclusivity, caring, and effective. Another comment was, she's bought in clothes for patients that are homeless, and she will even go to the canteen and get them nice things to eat out of her own pocket. She anticipates what patients need and has such a kind and caring nature. We will be lost without Marina. I think on behalf of everyone at CERU, a big round of applause, Marina. Thank you very, very much for everything you do. And Marina's example is just one of countless daily examples of our staff going the extra mile in often very difficult circumstances, sometimes, frankly, with patients who don't appreciate the kindness that's being shown them, but nonetheless with a good heart and a desire to help. They go the extra mile in their own micro ways. But Marina, you are quite exceptional. Thank you very, very much. Our team winner is our volunteering team, and hopefully a number of them will be present, including Fran Doherty, who's the lead for volunteer services, Denise Phipps, volunteer project coordinator, and Amy Upchurch, our health and wellbeing centre volunteer lead. And we have so many volunteers throughout the organisation. So they're the annual winners for this year, and they look after and volunteer the team serving at Warwick, Leamington Spa and Stratford-upon-Avon hospitals. And they won the summer team Going the Extra Mile award for recognition of their dedication and support. And again, I'll read out some of the nominations. One nominator said, the team is integral to the daily operations of the hospitals, always stepping in when needed, whether it's responding to last-minute requests from A&E during crises or providing critical support for palliative care patients. They work tirelessly behind the scene, covering all aspects of hospital life, from guiding patients to their appointments to assisting homeless patients in need. The nominator continued, the volunteering team is the backbone of our hospitals, consistently approaching every challenge with professionalism, care, and commitment to safety. Their work is vital to the functioning of Warwick, CERU, and Stratford hospitals, ensuring that both staff and patients are supported in every situation, no matter how urgent or complex. This team embodies the Trust's values. So I think, again, from everyone on the call, a big round of applause and thanks from everyone in Warwickshire for our volunteering teams. And if you're listening to this call and maybe are uncertain about whether you want to volunteer, I would really strongly encourage you to do so. Volunteering is not only something which helps others. In my experience speaking to many different volunteers, it often gives a purpose to people who are sometimes wondering what to do in their retirement years. So volunteering, we try and be as flexible as we can in terms of accommodating your time availability. But if you are considering doing it, please bring yourself forward, and you can go through the website to contact our volunteer teams. And I think you'll find it a wonderful thing to do as often as you're able. So before we go to the presentation, because we are running a little bit early, we did have some questions from members of the public. So Sarah, shall we take those now, please?
Thank you, Russell. So the first question is from a member of public who would like to know why it's taking up to 6 months to see a gynaecologist when referred by the GP. Is this because they are not being paid enough by the GPs, as it is possible to get in immediately if paying private? And these are the same consultants that cannot see you under National Health. Also, can we please have more parking for patients, not large shops on site? I think Harkamal is going to answer. Thank you, Russell.
Harkamal, over to you.
Thank you. So with regard to the first question around gynaecology wait times, so you'll know that we have been working really hard to recover our waiting times for routine treatment, and gynaecology has seen areas of significant progress. So we have done quite well in terms of recovery since COVID, and we don't have any patient waiting over a year and a half and now we're coming up to a year for treatment. We have seen record levels of demand though for cancer. So for gynaecology cancer, our referrals are higher. So we have been trying to get the balance right in terms of providing capacity for cancer as well as for routine outpatients. That said, our waiting time at South Warwickshire is slightly higher and is slightly lower than the system average. And I think that demonstrates how well we're doing. And we are on a trajectory to get back down to more acceptable waiting times. It is a long time. I do accept that, to go to your GP and then to navigate your way onto a waiting list in a hospital. I absolutely hear the concern from our patients, and we are working with GP partners as well to try and make sure that if there are any patients of concern, that they are referred under the right pathway. So utilising the 2-week wait and the urgent, so we can make sure that we're pulling those patients forward. We haven't seen any significant risk with those waiting times. And so I am assured that people are being transferred on, referred on the right pathway. With regard to the aspect of the question around private patient access, some of our consultants do private practice, and that's the same for a number of our consultants and a number of specialties. It hasn't got anything to do with pay from GPs. It's a choice that our consultants make, and for some of our population who choose to access private services, they do so and they go and see those consultants privately, and those consultants work for the NHS as well. So that's the first part. In terms of the second part of that question,
Harkamal, just before you go further, just on that point, because it is an interesting issue that's raised by that question. Unfortunately, that goes back to 1948, the way the NHS was set up. And to get the NHS set up originally back in 1948, consultants were given the liberty of being able to have their own private practice. And there's effectively nothing we can do about that. If they choose to have a private practice and develop a private practice, that is their right. It's effectively done in the time that they're not working for us. But we do recognise that issue. But it does go back, unfortunately, to a founding principle of the NHS. On the car parking question.
Yeah, so thank you for the question. And I have to say, I do agree with the points. I can only apologise firstly for the impact that the building work is having. I think you referenced it at the start of the meeting in terms of the significant amount of work that is taking place to modernise the estate and provide some much needed capacity for our elective recovery. We are trying where possible to encourage patients and members of the public to use alternative modes of transport, and there are a number of things that we're doing to try and address that. So there's a new project with Smart Travel to start mapping out where patients are coming from, so we can work with Warwickshire County Council and help inform some of the future transport strategies. They sit outside of our control, but we're very keen that we want to be part of that solution. So we're doing everything we can to be part of that conversation. We also try and do as much as we can virtually and offer digital solutions where appropriate to try and make sure that people are only travelling when they need to. And that work is ongoing. We're also trying to make sure that we are providing clinics out in Stratford and in other community areas so that we can limit the number of patients having to come to this site. That said, the building work is significant and we're doing our best to manage that as best as we can. We do have a long-term estates plan that does include a separate entry and exit point. And so once we have a bit more capacity and we can create some of that space within the car park, the point around can we have an entry and exit to hopefully do a more swift drop-off, that we are trying to map that into the future for transport and drop-offs at the Swift site, at the Warwick site.
Thank you, Arkema. It's a very difficult issue, this, and we spent £8 million, I think, 4 years ago, building a multi-storey to increase our car parking capacity. And Harkemel's point about the bus routes and bus availability, I think, is an important one, but there's no getting away from it. At the end of the day, the Warwick Hospital is based effectively around a housing estate. And so we are trying to fit a court into a pint pot, to use an old-fashioned phrase. And given the increasing population around Warwick, it is a real need for us to increase our capacity, hence the pain we're having to go through at the moment. But we all recognise the difficulties of practical issues it has. So all we can do is apologise and say we're trying to get the work done as quickly as possible, which is why I had a shout out for our estates team, because I think they're doing a remarkably good job at trying to make it happen as quickly as they can. Glenn, is there anything you wanted to add to this?
Yeah, just to add a little bit more. I mean, within that question, there was something about the inclusion of a shop. I mean, firstly, to say we have limited access to capital. A few years ago, we would have been able to borrow as a foundation trust. That option has not been available to us for the last few years. So part of the way that we're financing this particular patient enhancement to the site is through a franchise arrangement, which has provided the capital funding to do that. Also, though, it's an enhancement which our staff are really pleased to see happening on the site, and will be an enhancement for visitors also.
Thank you, Glenn. Are there any other questions at this stage from members of the public? If you want to raise a digital hand, please do so, or come off camera and wave frantically at me so I'll be able to see you. Sarah?
Thanks, Russell. We did have a second question from a trust member, but that was about car parking, which Harkemal has answered that question in her response.
Okay,
thank you.
Thank you. Okay, Duncan, are you able to start the presentation on the prevention agenda that we've got and the use of data?
Yes, I can check. Can I just check? Can you hear me first? Is the first question.
I can hear you perfectly well. Thank you,
Excellent.
Duncan.
Great.
Hi, Helen.
So for those of you who haven't met me, my name is Duncan Vernon. I'm a consultant in public health here at Trust and the Deputy Director of Public Health in Warwickshire, working across Swift and Georgia and Swift and the County Council. Firstly, to say I was delighted to hear about the topic chosen. It's an increasingly important topic. Firstly, to ensure that healthcare services are sustainable, but also importantly, the same reason as we do everything else. We want to prevent ill health because we want to improve the quality of life of our patients and the population that we serve. We do a lot of prevention on site in the community as a trust. Most patients, I would say, experience it as the effective and compassionate care that we provide. But actually, whatever we call it, it's a big strategic aim for the Trust. And actually, today, what I brought is a couple of case studies to help us understand what we are doing, help to recognise the role that we're playing as in prevention as a Trust, and also hopefully encourage people and other members of staff to play a role. This is something, as Glenn said earlier, it's one of the big moves, and trying to embed it in every service. And we need our prevention champions. Hopefully, this presentation will help understand what prevention is and those opportunities. So this is what we'll cover. As I say, we have several case studies ranging from maternity to a data-driven approach to diabetes, transformation and supporting patients with complex diabetes, as well as some of the work we're doing around tobacco dependency and embedding prevention into quality improvements. Finally, at the end, looking forward to taking questions and any comments from the presentation as well. I wanted to firstly introduce the public health team here at Swift. We do have a small core public health team of ours. I say one of the core messages I hope is that everyone will start to see their role in public health and prevention by the end of it. There's myself, and I'm also joined in this presentation by Kate Rushell, who's our Senior Population Health Manager. Again, a joint role leading on a lot of our data and intelligence and population health intelligence work and how we're making best use of that as a trust. And Dr. Helen Webster, who's a Specialty Registrar in Public Health, who's been with us on a placement less than full-time for around 2 years. Sadly, Helen's now in her last month at the Trust, and I hope she won't mind me saying thank you to her in this public place, just to say I will miss your leadership and work that you've done on this, Helen. Thank you so much. So I think part of the brief was that it's not to be a data-heavy presentation. I hope you'll indulge me just one graph, and I will talk it through. So what this shows is life expectancy and healthy life expectancies over time in Warwickshire. So up the left-hand side, the scale, we have the age of life expectancy and healthy life expectancy. Along the bottom, we've got times. So as you read left to right, you're going from 2001 to 2022, which is our latest data that we have for this. The first two lines I want to introduce you to are the top two. They're male life expectancy in yellow and female life expectancy in blue. Now, life expectancy is the average length of time that you would expect to live in good health. You expect to live. There's a couple of trends here. You can see, for example, that from about 2001 to 2013, you can see that this is increasing over time. You mentioned 1946 earlier, Russell. It's been increasing ever since then at a regular rate. And then since then, we've had an inflection point, and you can see at best, life expectancies are stalling, and at worst, it's reducing. The lines at the bottom are healthy life expectancy. They're the average length of time that you can expect to live in good health. Obviously, you can see they're much lower, and you can see this trend is much starker there. You know that we can see that it's going down, actually. And again, we have a few less data from this, but you can see those two bottom lines. There is a very clear trend. And actually what that means is that people in Warwickshire and people in South Warwickshire are spending more time in their life living in poor health. It's this gradient and the gap between the two, which is of concern and the reason why prevention is so important. And of course, this is population average. So many people living in more deprived areas or more difficult circumstances will, of course, have lower life expectancies and healthy life expectancies. We can see here, it's a point made by Drazi in his report, and again, that was mentioned earlier. Recognise, of course, the increasing pressures on our services, the increasing challenge to keep a show on the road, and all the admirable work that keeps to deal with that increasing demand that was mentioned earlier. And this challenge isn't an NHS one. It results quite heavily from poor health. We know that life expectancy is stalling, healthy life expectancy is stalling, and that has impacts on NHS performance. We know we have an ageing population, but actually the fact that it's ageing in an unhealthy way is what is causing a lot of demand and a lot of pressure. Many of the risk factors that we know cause poor health, cause will cause many long-term conditions. I'm thinking things such as smoking, I'm thinking of diet, I'm thinking of obesity, physical activity, and alcohol, for example. So actually, as well as increasing numbers, we're dealing with increasing complexity because of these risk factors. So what can we do about it, and what impact will it make if we do something? This is a quote from Chris Whitty, who I hope needs no introduction, but Chief Medical Officer for England, and has been a strong advocate for improved public health during and since the pandemic. What happens if we prevent it? Well, his line is 40% of healthcare spending is on preventable illness. And I see the same when I look at our Warwickshire data. 40% of long-term conditions in Warwickshire are preventable. And again, when you think of the major causes of harm, thinking things such as cardiovascular disease, lung disease, cancers, liver disease, and of course, mental health conditions. So actually, a great deal of that is preventable if we act upstream to prevent the causes of it and the causes of the causes. But a lot is within our gift as a trust. And importantly, looking back at that graph that I showed you, what prevention will do and what it increases life expectancy, yes, but it increases healthy life expectancy more. So it reduces the amount of time that you spend in poor health, and reduces the amount of time that you might want to use NHS services for. Next slide, please. Thank you. I also just want to quickly talk through what we can do about prevention and the different types of prevention. So it's not all upstream, and there are things that we can be doing further downstream as well. Yes, primary prevention is so critical and important, tackling the risk factors that lead to poor health. But there's more that we can do around secondary and tertiary prevention. So actually reducing the impact of a disease and injury that's already occurred, for example, by detecting it and treating it as soon as possible, or identifying other comorbidities in patients and how they might receive further support for them. Or finally, tertiary prevention. So actually, once we know that people are ill or have an injury, that needn't negatively affect their quality of life in as huge a way as it could do. So again, there are opportunities to help people manage complex health problems. And again, that has an improvement in their quality of life and reduces their poor health. I'd like to pass over now to Helen to introduce our first case study on maternity services.
Thank you, Duncan. Hi, everybody. As Duncan said, my name is Dr. Helen Webster. I'm a specialty registrar in public health, coming towards the end of my training to be a consultant, and it's a real pleasure to be with you here today. So let's jump into our first case study, where we're going to be looking at maternity services. Why focus on maternity then? We know that pregnancy and the early years are vital, and this is why they're a focus for our Prevention Big Move this year. You might have heard of the importance of the first 1001 days. This is from when a baby is conceived through pregnancy and birth to the first 2 years of their life. We know that during this time period, we lay down the foundations for physical and emotional health throughout that child's life. 80% of brain development occurs by the age of 2. So our maternity services are really vital, but they're facing challenges as well. They're facing increased population growth and complexity. We've had 14% growth in registrable births. We've got an increase in pregnant women who are over 30 years. If I can draw your attention to the bar chart at the bottom, that big bar in the middle that's sticking up, that's our 30 to 34-year-olds, women at the time that they book with their pregnancy. Almost 1 in 5 of our pregnant women are obese with a body mass index over 30, and 7% of them smoke. So deprivation and inequalities, they're a really critical factor in our maternity services. Now, I'm delighted to introduce to you our public health midwives, Sally and Claire, who are working to improve the health of those using our maternity services. So over to you, Sally and Claire.
Good afternoon, everyone. So I'm Sally Talbot, I'm the public health midwife. We would just like to sort of move on from the statistics that you just heard and try and show you what we're doing in maternity to try and improve care, to try and prevent longer term impacts. So we use all that local and national data to implement the services that we hope will improve maternity outcomes, but will also positively impact on the longer term health of the families that we see, especially when they're going to need to access NHS services probably later on in life. From our perspective, some of the projects that we work in, so we have a smoke-free pregnancy project, tobacco dependency project, which we support women in-house. We provide maternal and neonatal vaccines. We have a weight management in pregnancy project. We have a poverty proofing project, which we're going to talk about shortly. And then we also have quite a strong focus on complex pregnancies and health inequalities. And some of those at the moment are including domestic abuse, alcohol and substance misuse, young parents, and then the newly arrived and asylum seeking populations. Obviously, there are many sort of remits within public health and many things we can do to assist with prevention, and Claire and I are only 2 people, so I just also wanted to let you know about some of the other initiatives that are happening in maternity. So we do have an infant feeding team. We do have a diabetic team for maternity now. We've recently introduced a perinatal mental health specialist midwife, which is brilliant for some of the statistics you heard from Helen before. We have a patient experience specialist. We have a bereavement midwife specialist. We have an antenatal screening team. We are currently doing a parent education review and working in collaboration with our local charities, with our Maternity Voices partnership, and with all our stakeholders to work out what should be in our parent education offer. And we now also have a digital midwife specialists who assist us to make sure that everybody can get on board with their maternity records, what we can offer them. So I think that part of it's really, really important. Mine and Claire's role really is to embed all these public health initiatives into routine maternity care. So we want to make sure that we're offering the right support to everybody that needs it at the right time. We also want to make sure that we are making every contact count. So we do offer nearly all of our services at multiple occasions during pregnancy. So none of them are a one-off offer. If you could just go on to the next slide for me, please. So a little bit about our progress. So we do work towards national targets and local targets. And one of those is our Saving Babies' Lives target and a long-term plan target. One of the things that all maternity services have been tasked with is to reduce the amount of women smoking at the time of birth to below 6%. Over the last few years, nationally, we have reduced it from 11 to 7%. And from a Swift maternity perspective, we have reduced our smoker at the time of birth from around 6 to 7% down to 3 to 4%. And this month's figure is 3%. We also have a tobacco dependency target. And this is making sure that we see our women in-house. We have an external service that see women as well, but we want to make sure we see them during their maternity appointments. And for the last 3 months, we have been able to support all of the women we needed to and offer stop smoking support and help to quit. And that target is now at 100% for us, and we're achieving it. We have a vaccination team. And our vaccination team deliver the maternal and neonatal vaccinations. Just as an example, so the numbers on the slide are slightly wrong. I've just reassessed it this morning, but in September we delivered 290 of the new respiratory virus vaccine. We delivered 241 flu vaccines to maternity patients. We delivered 169 whooping cough or pertussis vaccines, and we vaccinated 50 babies with BCG. We have recently also launched what we've called a public health Padlet, which is for every stakeholder in maternity to use, and it's a really good signposting tool, which Claire will talk about shortly. With all this progress, you know, one of our biggest concerns is addressing the health inequalities of our population and trying to make sure we get care right for everybody. So some of the things that we have done, and this is, you know, this is a short list, but some of the things we've done, we now deliver our vaccines on both the Warwick and the Stratford site. We deliver them alongside appointments, maternity appointments. So we don't expect anybody to come in for an extra appointment for a vaccine. We don't expect them to do any extra travel, and we don't expect them to need to park or pay parking costs, because we can do it all in one. We review all of our smokers that decide not to accept support. And what we have found in the majority of our reviews is our white British population. And then we go a bit more deeper and we look at where they live, what are the risk factors they've got in pregnancy, what other support they might need, is their smoking linked to other factors in their lives, and we then try to find ways to work around that and give them the right tools to make an informed choice on whether they should quit or not. And an example of this is one of the new services that is coming in with our Stop Smoking in Pregnancy team is maternity incentives. So we will be very shortly offering vouchers to pregnant smokers to support them to quit. We also review all of the families who decline the vaccines, and we have a recall system in place to make sure that we can re-offer it on multiple occasions following extra discussion to make sure they've got all the information they need. We've recently put into place a multidisciplinary team project with CGL, which is Change, Grow, Live, so our alcohol and substance misuse support. And that helps us to know what's going on from their perspective with our clients and what's happening in the hospital, so we can actually work together to put in a really good individualised plan for everybody. The Poverty Proofing is an online learning platform which Claire will discuss. And then I think the other thing that's important to know about what we're doing in Maternity for Public Health is that we are collaborating with everybody, basically. So we are working with health and social care, we are working with the voluntary sector, community sector. We work very closely with the local maternity and neonatal system, family information services, Warwick migration team, and again our Maternity Voices partnership to make sure that the stakeholders' voice is included in what we're trying to do. I'm just going to hand over to Claire.
Hello there, I'm Claire. I am the Deputy Public Health Midwife, and I'll just talk a little bit more about our poverty proofing, just following on from what Sally discussed. So we are talking to and working with a lot of our MDT colleagues from both health visiting, children's services locally, but we're also talking to other trusts nationally just to see how we can help more at Swift. Just to address this poverty proofing, we've identified 4 main areas that we do need to focus on, as you can see on the slide there. We recently sent a staff survey out to all of our maternity department just to identify any gaps in their knowledge or their training regarding poverty proofing and how we can support that. The feedback demonstrated that staff wanted a tool that they could use with birthing people and their families, appropriately signposting them to local support, whether that be financial support, emotional support, housing concerns, accessing services, or even getting baby equipment, food banks, local food banks, that kind of support. As a result of this, we developed the Padlet, which Sally previously mentioned. The link is on this slide here. This Padlet has a long list of information that women can access. It is available in all different languages that you can use on the Padlet. It's available on video support and also Braille. You can access it and order in Braille. So staff who are supporting women can also access this as well. So it's really kind of to be accessible to all of our women and our patients. We've also introduced annual mandatory training for health inequalities in maternity. This was completed in September from all of our staff. That's from support workers, midwives, doctors, everybody was accessing that training. So hopefully that will now be an annual thing. We'll update that as we go to include the most important local and national guidance for all of our staff. I hope that is useful to you. Please feel free to access that link in your own time if you can, and I will hand back to Helen. Thank you.
Thank you so much, Sally and Claire. So quickly, the last slide on this case study about how can I help myself. We know that being pregnant and having a baby can lead to a lot of mixed emotions for women and their families, and it can be hard. The most important thing to know is that you are not alone. Please do speak to someone about any concerns or struggles you may have, whether these are physical health, mental health, financial, or related to smoking, substance misuse, or alcohol. Speak to your midwife or someone you trust, and you can also visit the Swift website and the Warwickshire County Council website to learn more about what help is available. And now I'm going to hand over to Kate for our second case study.
Thanks, Helen. Good afternoon, all. My name's Kate Bushell and I work in public health here at Swift. So I'll be introducing some of the diabetes work we've done, and then I'll bring in Bhaskar, who'll talk through some of the key messages from the work and how we've used this insight to shape improvement. Okay, so firstly, just focusing on why diabetes. So we know type 2 diabetes is a common long-term condition that causes levels of sugar in the blood to become too high. At a population level, we know some of the contributing factors that make people more likely to develop diabetes, and some of the national statistics are highlighted on this slide here as well as the rising costs associated with type 2 diabetes, which we can see nationally here accounts for around 9% of the annual NHS budget. Particularly drawing out factors here, key risk factors here around ethnicity, weight, and deprivation. And I guess knowing these risk factors and understanding them more helps us to understand what we need to address to prevent so many people from living with diabetes. And there's a lot we can do, not just as a trust or as a healthcare system, but also by influencing and working with other organisations. So a little bit more quickly about the transformation project we undertook with diabetes, taking a data-led approach. So this project was looking to establish a virtual meeting to discuss care of diabetes patients at greatest risk based on key clinical risk factors with a multidisciplinary team across both primary and secondary care. The team consisted of consultants, practice nurse, dietitian, GP and other staff in primary care. As well as the great collaboration between primary and secondary care and other key stakeholders, we use linked data to target patients that will benefit the most from this approach. The linked data we were able to use for this project was linked primary care or general practice data, joined with our Swift secondary care, secondary care, acute and community data to give us a much more rich and holistic and broader view of our patients across different healthcare settings, rather than just relying on one source. And this includes things like being able to look at deprivation, being able to look at key health inequalities data. And this is something, I guess, to highlight that we'll increasingly have access to across the trust and will give us much more comprehensive understanding of our patients to be able to identify groups of patients and better understand our population to help improve health outcomes, but also really importantly to prevent patients from needing more intensive and costly treatment for their conditions. I'm going to hand over to Bhaskar now to talk through the next couple of slides, and then I'll wrap up at the end with some support available for those with diabetes. But Bhaskar, over to you.
Thank you, Kate. If you can move to the slide. So yeah, this was a great opportunity because this was just as we were recovering from COVID and the ICB and NHS had primed a little bit of initiative to recover from the backlog that we had encountered. And in some ways we were kind of in line with what the Darzi report and the direction of left shift of care, etc. came. So this couldn't have been better timed in terms of having this enriched linked data set to get what I feel is a bird's eye view of the demand. Because at the moment, we're working in silos, waiting for the ones that are coming through the system and dealing with that to the best of our abilities. And it, of course, is effective, but what we don't know remains an unknown. And in some ways, it's not really a rocket science that if you match up the data, you get a much different perspective of what the demands are. And it not only highlights some of the unmet needs and focuses on this deprivation and lack of access, but it also allows us to actually start being clever about where to invest our best value, because not only was the linked data set clinically identifying risk, it was also focusing on those wider determinants. And for the first time in my life, I came across a dollar symbol coming across the various segmentation of our population. So for example, we worked together with our North Warwickshire partners, Public Health and ICB to fragment or segment the population based on primary, secondary, and tertiary type risk. And while the virtual MDT was just one enabler to nibble away at some of this risk, it, like I keep saying, gives us a much better perspective of what the demands are. And for example, I came out with new knowledge that there are 150 18 to 29-year-old type 2 diabetics out there. And these patients are obviously not in trouble now, but these are the ones that worry me in 15 years' time, when they will still be only 40 to 50, knocking on our coronary care or our stroke unit or our dialysis unit. So in some ways, to actually synthesize and crystallize that number, and then if we match the science data of what can be done to address these young onset at a very early stage, if possible, prevent and remit their diabetes to no diabetes, or if they can't be cured, at least hammer their risk factors at a much earlier stage, is really a good opportunity for us to really invest a little upstream rather than the constant firefighting we've kind of got around doing for most of our life. If I can move to the next slide. What this bird's eye view gave me, even as what I would call as a senior clinician who should have known all these, is, first of all, for all an affluent population that we're supposed to be, we're not one size fit all. There are pockets of deprivation within us. Not only that, the deprived ones, unsurprisingly, also had greater prevalence of complications. Chicken or egg is another day's debate, but there is strong correlation that even for all the headline of an affluent part of the country, we still have pockets of unmet need patients who are also at higher risk. And it, like I said, with the 18 to 29 new onset type 2, which to me is a atom bomb waiting to explode, even if it's 15 years from now, because they are really the most at risk. And whatever effort we can do to invest and recover some of that damage is really going to be hopefully cost effective. And that's where I think this data needs to then move towards a comprehensive review of facilitating commissioning decisions with quick review of whether it's worth investing like this as well. So it really is an exciting time. And if you can move one slide further, Kate, and I'll stop with the fact that, like I keep saying, the virtual MDT was something we were setting up anyway as part of COVID recovery. And while our initial work was with individual practices and practices identifying typically on unmet clinical needs based on their glycemic control or blood pressure or cholesterol, increasingly with the linked data set, we're now rolling out to the remaining 5 PCNs within South, where we will start identifying targets that are slightly different to what primary care alone had. And therein lies another opportunity. If I have a list of people who are revolving door with frequent ambulance callouts or ED visits, that still is secondary prevention or tertiary prevention. So prevention doesn't have to be just no diabetes or diabetes to no diabetes. It could be advanced diabetes to less advanced and so on, secondary, tertiary. So I think in some ways, this is simply one example of where we are already truly working together. And the data set is now feeding us a slightly different set of patients to what we were used to. But the framework we're setting not only is putting to test, and we're monitoring the key performance indicator of whether all this time we've invested discussing the 2 PC and 70 cases so far is really clinically effective. And of course, we have to sit on the fence on that one, because the KPI monitoring has to tell us whether this is worth of my time investing 3 hours every 2 weeks to discuss a new set of patients I wouldn't have come across until later in their journey, because the referral pathway is set in such a way. So it's about nibbling away at unmet needs at an earlier possibility, with somebody clever working out whether it's cost effective and clinically effective. The answer might still be yet to be known, but I do genuinely think that this framework and integrated working is something I'm keen to propagate, not just with diabetes. And for people who don't know, I'm going to step into the CMO role soon, that I'm looking at public health to facilitate similar pieces for our heart failure or COPD or other key medical and other pathologies that we need to start going upstream, because doing more of the same isn't going to get us out of jail on this one. I'll stop there and pass it back to Kate.
Thanks so much, Bhaskar. Just last slide from me then, in terms of we know getting a diagnosis of diabetes and living with the condition is really difficult, but I wanted to highlight a service we run here at Swift called Desmond, which is the Diabetes Education and Self-Management Programme for ongoing and newly diagnosed patients. This is a structured education programme, and more detail about it is on the screen there, but the text box is on screen. There's some feedback about Desmond, which is really good and positive to hear. But there's also an online offer, so we can self-refer from the Trust website, but also there's an online offer now called My Desmond. Additionally, there's loads of other support available on how to keep active, weight management, diabetes in pregnancy, mental health and wellbeing support, and these are all accessible via our Swift webpage on the screen. So I'll hand over to Helen now to talk through our third case study on tobacco dependency. Over to you, Helen.
Thank you so much, Kate. Yep, so let's jump into case study 3, tobacco dependency. Why are we looking at smoking? I think the title of the slide says it all. Smoking remains the single biggest cause of preventable illness and death in England. We know in Warwickshire, over 1 in 10 people smoke. The graph at the bottom of the left shows you with tobacco dependency, that big dark blue one at the top, that smoking tobacco causes far more harm than any other behaviour. The coloured boxes show you just how harmful it is. 1 in 4 UK cancer deaths are linked to smoking. 2 out of 3 smokers will die from smoking unless they quit. And smokers lose, on average, 10 years of life. Additionally, smoking increases your risk of a heart attack or stroke, increases your risk of dementia, and it worsens mental health. We know that the majority of smokers want to stop smoking and regret starting, but nicotine is, of course, highly addictive and quitting can be difficult. That is why we are really proud of our inpatient tobacco dependency service that was launched last February. All patients that are admitted to our hospital overnight are referred to the tobacco dependency team, who visit the patient and give them the support that they need. The next slides are provided by our tobacco dependency nurse, Leslie, who sadly couldn't be with us today. She's given some slides and she's given some audio with it as well. It's a little bit quiet, so if I could just ask everybody to increase the volume on your computers or laptops or phones, so you can really hear Leslie. Thank you.
Hello everyone, my name is Leslie and I am the Tobacco Dependency Nurse Specialist for South Warwick Hospital and George Eliot Hospital. I do apologise I could not make it to the virtual room today, as I am off enjoying some well-deserved annual leave. However, I wanted to introduce you to our teams and the wonderful work we've accomplished so far. As you can see from the photos above, we take great pleasure in sharing our knowledge and supporting healthy futures for our patients through sharing awareness in the ward areas and non-smoking campaigns across the hospital grounds. These activities support patients, staff and family members. We also deliver tailored management plans to our poorly patients at their bedsides. This helps to treat them with their withdrawal symptoms, support and guidance, and deliver that health education. But most importantly, we listen to what the patient requires from us to get through this journey. So as you can see from the data, the teams have worked incredibly hard to see all the patients that are admitted to hospital that smoke are offered a quit management plan. And as you can see, from February 2023 to September 2024, the team at Swift saw over 1,000 patients. This is the last slide from me. I just wanted to share with you all how well those services have been received across both of the trusts. We've had great engagement from our patients and colleagues, and I'd just like to share a few words from one of our patients. Each month is better. Less cravings. I don't feel like it's hard to do anymore. Breathing is better. It just feels natural. No one can believe I have done it. And it's all thanks to you and your team. Thank you.
Super. So I think that gave you a really nice snapshot of our inpatient service. I'm going to very briefly talk to you about a pilot we're developing to create a tobacco dependency offer within pre-operative assessment at Swift. We know that when people are waiting for an elective operation, they are highly motivated to improve their health to give them the best recovery possible. We also know that if someone is able to quit smoking, this reduces the complications both during and after surgery. Therefore, we're developing a service that when somebody goes to preoperative assessment as a smoker, they can be given tobacco dependency support to quit smoking before their operation. We're one of the first trusts to be developing this service, so it's really exciting. And to close this case study, how you can help yourself. What I think the big message from this is that it is never too late to stop smoking. There are always benefits. After just 72 hours, your breathing becomes easier. After 3 to 9 months, your lungs work 10% better, so you have less cough and wheeze. After just 1 year, your risk of a heart attack has halved compared to a smoker, and the benefits continue. Anyone living or working in Warwickshire can get free support to stop smoking. The website is smokefreecw.co.uk. And so for our final case study, which is looking at training, development and improvement. So we recognise that in order to be able to embed prevention into every service, we needed to increase awareness, upskill and provide education and teaching. You can see from the slide there are lots of ways that we have been doing this. One of these is through the preceptorship programme. This is for newly qualified nurses or nursing associates who are either brand new or are returning to their practice at Swift. We've been teaching them about social determinants and prevention and have taught over 100 people so far, with lots more cohorts to come, and our allied healthcare professionals are joining the sessions too soon. One other example I wanted to share with you is an allied health professional leads away day that we ran. We focused on AHPs for the first away day, as we know that they do a huge amount of prevention within their work, but it isn't always being recognised. This was a fantastic day. We were joined by the Deputy Chief AHP Officer for England, who helped set out how AHP's roles in all public health areas. Through this, the leads have been able to support their services to define their roles in prevention and public health, thinking widely about how they can improve health. And you can see 2 examples of this on the slides. Without further ado, I'm going to hand you to Emma, who's going to talk to you about prevention and improvement.
Thanks, Helen. Okay, so my name's Emma Rowan. I'm Head of Service Improvement at Swift. And similarly to the public health team, we're a small team, which means that one of our responsibilities is to make sure that improvement is everybody's business and give them the tools to be able to do that. So the way that we do this is through something called our Quality Service Improvement and Redesign Training. And as and so in the same way that prevention is everybody's business, it gives a good opportunity to make sure that people working on improvement are thinking about prevention, and people working on prevention have the tools to be able to do this. So putting it into training is felt like a good idea. Next slide, please. So our improvement training offer has a lot of different levels. I won't go through them all, but you can see this is the number of attendances, the number of times that people have accessed our training at each level. So the level of expertise goes up in line with this model and with the number of people that we expect to have trained in methodology. And you can see the levels that we've embedded prevention. So it's already embedded within our introduction to improvement. And so we will hopefully start to see the impact that that's having. And we're just rolling it out to our virtual and practitioner programs. And in our virtual and practitioner programs, we expect participants to run a project alongside attending the course, which means it's a great opportunity to be talking about prevention and getting people to think about prevention as part of the improvements that they're making. Thank you. Next slide. So what's the impact that this is having? So we send out a survey to everyone 6 months after they've attended the training to see what impact the improvement training has on them. So this is just to demonstrate that improvement training enables people to feel empowered to undertake an improvement project, and they're able to make improvement in their day-to-day roles and develop their careers as a result of attending their training. Next slide, please. And we also ask what projects they're doing and what the impact that this is having. And one thing we notice at the moment is that a lot of these projects, if you think about the primary, secondary and tertiary prevention that you've heard about, a lot of these projects do have prevention benefits, but they're not always being identified in that survey as having a prevention impact. So what we're hoping is we'll see a change in that as we move forwards with delivering our training, and people will be able to identify that they are embedding prevention within their improvement. This also shows as well how beneficial it is to have people attending our training, and the huge impact that it can have across our different services by having improvement as everybody's business, and the impact they'll have also on prevention. So the way we've embedded it is to just drip through all of our modules so that people just get references to prevention throughout, so that it's not seen as something separate, it's not seen as something different, but prevention is something that they have to be thinking about when they're thinking about improvement. Thank you. Next slide. I think I hand back over to Duncan at this point.
You do indeed. Thank you, Emma, and thank you to everyone who's presented in all of our case studies. I hope that has helped to show the range of things that are happening across the trust, and it's just a small sample of them. I think to be most effective, we can think about how to embed this everywhere. If we're all working together on the same issue, it becomes a lot more impactful. And again, there's a couple of other things that we've been promoting as well. Some of this we talked about in terms of prevention as part of improvement projects, how we're supporting prevention education and public health education more broadly. We've been promoting a tool called Embedding Public Health into Clinical Services, which is available on e-learning for healthcare, and the website is there, and would hugely recommend people have a look at that if you're responsible for sort of running or delivering a clinical service. And similarly, talking about some of the things that we've had in place for a while, but how to make them real and how to rejuvenate issues such as making every contact count. I, of course, have to mention that when we're talking about prevention, it's not just the patients and our population. We also need to be thinking about the health and well-being of our own staff. And there's, of course, a lot of work that's happening throughout the Trust in order to promote that. So just finally for me, before I hand back to the discussion and questions, I think getting our approach to prevention is critical, and I hope that what we've been able to bring in the public health team is a consistent messaging and consistent priorities to help embed everywhere. But actually, this is something that we can all pick up and run with. There are lots of examples across the trust, lots of other people who we could have approached and asked for examples, and you know, we sort of had to whittle this down from a long list to sort of try and pick a breadth of activities. But there's a lot going on. But similarly, there are big opportunities, and no matter how small, any action that we can do to improve prevention is beneficial, because we are at our most effective when we're all doing it and we're embedding it everywhere. So I'd like to thank you. We've probably got a couple of slides just on links and similar for when they are circulated, but I'd like to open the floor to any questions or comments.
Thank you, Duncan, and thank you, team. That was a fascinating presentation. And just to contextualise things a little bit more in terms of the challenges and the importance of shifting to a prevention agenda. Over the last 12 years, the population of Warwickshire has grown by 8.9+%. Over the next 20 years, it's forecast to grow by 15%. We're seeing an enormous growth in our local population, and we're trying to fit a quart onto a pint pot if you take Warwick Hospital. The challenge of demand is enormous. Second big challenge on demand is the aging population. And we've touched on nicotine and sugar. They're arguably the two most addictive drugs known to the Western world. And so we cannot build enough hospitals, train enough doctors, train enough nurses, have enough volunteers to cope with the increasing demands that are going to be placed onto our system. And so we're here, as Duncan and team have sort of indicated, to help you help yourself, particularly with those enormously addictive drugs of sugar and nicotine. So members of the public, we know the challenges of changing diet are enormous. We know the challenges of stopping smoking or drinking less are enormous. So reach out for help. But it's incredibly important that you do so. About a third of our pregnant mums are on a form of antidepressant drug. And as we've indicated also, a number of our mums are clinically obese. The impact that has on baby is enormous. And so we want to help you, help yourself, help your families. Please reach out. We're here to help you, help yourself. Any questions arising from those presentations? Jean, one of our governors. Jean, you on mute. I know we do have problems sometimes with your computer, but I can't hear you. Jean, do you want to pop your question into the chat box? Because I know it will have been a good one. Any other questions or perspectives from anyone? Ruth, whilst Jean's typing away, hopefully.
It's really a question to Dr. Helen. I think I really admire you and your work with smokers. I was married to a smoker for 53 years, and he actually died of lung cancer. But he was not. He would not respond to any talk of stopping smoking. And I don't know how you reach out to people like that who are very, very difficult to turn around.
Thank you, Ruth. Thank you, Ruth. And I'm so sorry to hear about the loss of your husband. You're right, it's really difficult. It is absolutely extremely challenging. Our tobacco dependency team are really highly trained to help people. But of course, there are people who don't want support. And we really take the line of, like Sally was saying with maternity services, we keep offering it. You know, it doesn't matter if you declined it once, the next day you change your mind, 1 hour later you change your mind, that's absolutely fine. I think the only thing we can do is we use the evidence of the best approaches that work for people. We try and understand them, understand what their individual needs are, what their concerns are about stopping smoking, and try and create that individualized care. And if the patient doesn't want it, of course, we can't force it, but we just make sure that they know that the option is always available to them.
Ruth, you're back on mute. Ruth, you're on mute.
Apologies. What are your thoughts on vaping? Because that has become overly popular, particularly with young people, with quite a lot of detriment.
Yeah, so vaping is definitely a really big issue that we're looking at. We very much recognise the need to follow the evidence in public health, and still that remains the evidence that smoking tobacco is of the greatest harm. But that's not to say we're not looking at vaping, we're not thinking about vaping all the time, making sure we learn constantly what's coming out and how we can best address that, because you're right, it is a big concern. So I think the answer is that we are aware and we're keeping it on our radar while still focusing on what we know the greatest harm is in tobacco smoking.
Thank you.
Yeah, no, I agree with you, Ruth. I'm horrified at the amount of young people, intelligent young people, who vape. I just can't understand it. I mean, I'm of a generation when the tobacco companies were still disguising the realities of smoking causing cancer. But nowadays the evidence is clear. So, but when it comes to young people choosing to vape, not as a mechanism to come off of a nicotine addiction on cigarette smoking, but just choosing to vape, I'm amazed, absolutely amazed. Sue Walnut?
Thank you. Yeah, sorry, Duncan. I'm so pleased when you were appointed to the post within the trust of public health. It was such a good improvement. This trust is really committed to prevention. You hear Russell talk about it all of the time, and we absolutely have to do this if the health service is to continue. I was so impressed also with the services that the public health midwives were doing. Absolutely brilliant. It's totally needed. But if you don't mind, I'm just very quickly going to just talk about something related to that. It's the fact that I've worked as a specialist community public health nurse in the trust for the last 10 years, and I love it. And I and my fellow health visitors carry out all of those things that were talked about before, talking to parents about the effect that domestic abuse has on their children's future development, looking at healthy diet and exercise. All of those things are our bread and butter. We want to work with upstream thinking and prevention, and we do. Our advantage is that actually our caseload is every child living within Warwickshire, from 2 weeks old to until they go to school. We work in local communities, in teams within local communities. We know our local communities. We know what the issues are. We build links into the local communities to look at housing and how we can improve things, how we can look at postnatal depression and support for families. And I won't go on because this. I'm sure a lot of other people want to speak as well. But in those 10 years, I've seen the size of the community of the health visiting service pruned away. For no reason, not because of the trust. This is nothing to do with the trust. This is for outside issues around commissioning, and it's just a little difficult to see. Sorry, it's a little difficult to see services being cut when we know they're needed so much. So really, just all I'm asking is that we can have your support, please.
Yeah, Duncan, shall I answer first? So I think it is really important that one of the things Darcy talked about in his review of the NHS was the recognition that we need to shift the balance between spending our precious healthcare monies in the most expensive setting, the acute, and need to spend more of our healthcare monies in the communities and on prevention. So I really do hope that in the future, instead of spending about 70% of the NHS budget in the acutes, it becomes over time 65%, 60%, and a more than 50-50 balance. The issue we're talking about today is so fundamental to the future of the NHS in a situation of a increasingly elderly population, in a situation where we have about 10 or 15 years between healthy life expectancy and total life expectancy, when we see an enormous difference between life expectancy, for example, in Bedworth and Warwick. When we've got all of those challenges, prevention is the solution to these challenges. It is very difficult, as we know, when our citizens are coping with all of the advertising and social media and coolness around smoking or vaping, the attractiveness of ultra high processed foods. We're trying to stop that and do our best to address it. As indicated in the presentation, but we've got to shift our emphasis as a society to prevention rather than management of ill health. Glenn, did you want to come on to that? And Jean, I'm not sure if your microphone's working yet. Glenn?
Yes, Russell, I mean, obviously you just gave mainly the answer I was going to give there, which is that this was picked up as a serious concern as part of the Darcy review. And I think there's only 3 things actually within the Darcy review that have been identified as significant mission shifts for the NHS. And one of them is that shift from illness to prevention. The other is from analog to digital, and the other is from hospital to home. And we're incredibly supportive of those 3 being prioritised within this thinking. It is challenging. We obviously spend a lot of NHS resource on treating with today's problems, and we need to gradually slice out more money to prevent some of those unnecessary demands on the service. And the challenge here is that I think quite rightly the public health budget sits alongside local authority funding because it sits with the other wider determinants of health like education, transport, housing, those kind of things. But as a consequence, it is exposed to serious funding challenges that local authorities face. So I do hope that we see some movement on this as part of the new plans.
Thank you both.
And just going back on something, because you made a point which wasn't made in the presentations about domestic violence. I find it horrific that in Warwickshire, 11% of women claim to have been affected by domestic violence. In today's world, I just again cannot understand why men aren't getting the message, in particular men, aren't getting the message that to domestically abuse anyone, whatever their gender, is unacceptable, and the impact it has on children and the trauma it causes young children in young families is enormous. No one has the right to lay a hand on another person. You know, I do find it horrific. There's still 11% of women. And if you're the subject of domestic abuse, if you feel fearful of your partner, whenever you come into the orbit of our part of the healthcare system, please reach out. We have safe words. We have safe places to help you if you're the subject of domestic abuse. Jean, do you want to try to talk? Otherwise, I'll read out your message from the I can't hear Jean. Can you, Glenn? Okay, so I'll read out what Jean said. I want to make everybody aware that the work is extraordinary. Public health are brilliant at statistics, but today we have witnessed stats put into action. The evidence is great, but it is what you do with that is crucial. A suggestion: men with pregnant mum and new babies are often open to giving up smoking at that time. How are we doing at male suicide? Members of the public may not be aware, but most male suicides occur the year after the birth of the first baby in the family. Duncan, did you want to come in on that?
Yes, if I can. So Sally has made a point in the chat referring to the question about smoking and men who are pregnant. And again, the Stop Smoking in Pregnancy services supporting partners and other family members of pregnant smokers. And of course, we know that will reduce the impact of secondhand smoke on early child development and children's health. The suicide prevention is, of course, a big and a difficult issue to deal with, and you know, as you've mentioned, Russell, again, it is the leading cause of death for middle-aged men. There is a system-wide approach to this, which we've been supporting, and I wanted to just share the website in the chat, where if you live in Coventry and Warwickshire, you can find support for yourselves or for people who you're concerned about. It's called Dear Life, and you can see the link in the chat there. Again, I think this is a source of support, but also it's something that, again, if you're a member of staff and you can consider how you want to embed suicide prevention and the appropriate messages in your services, or want to make sure that you're knowing the right thing to families so you think about risk. And this is a good source of support for you.
Thank you, Duncan. And there's a wonderful charity called Sound of Silence. And just in terms of what we can all do to help colleagues who are going through a difficult time, is kindness and empathy towards people is absolutely embedded within our trust values, as well as civility. So if you do see a new colleague, who doesn't appear to have many friends, just as the smallest act of kindness and interest in their life can make an enormous difference. Fiona, there's a point made in the chat box. If you could kindly try and pick that up for me, Fiona Burton. Thank you, Anne. Hopefully members of the public will have seen from the presentation and the discussion just there just how seriously we as a trust take prevention and the prevention agenda. As we have used in a number of our strategy documents in the past, we're here to help you help yourself. As I've said, the future has to be about prevention. So the work Duncan, Kate, Helen, everyone on the call and who's given the presentation today, you're doing wonderful stuff. And Bhaskar, we're absolutely delighted that you are our new Chief Medical Officer, taking over the mantle like Elisha did from Elijah, from Charles to you, to carry forward with the good work that we're doing in this area. So thank you very much. I think that brings us to the close of our annual general meeting, ladies and gentlemen, unless there's anything else anyone wants to say. So hopefully the safe word will be in the chat box for you soon, Anne, but I know in our R&D departments there is reference to it.
I can't remember it at this point, but I will make sure Anne gets it.
Okay. Can we, actually, Fiona, could we get it popped up with a level of prominence onto our website?
Yeah.
Harkamel, do you know the answer? Sorry.
Sorry, Russ, I was just going to say it's not something that we would widely publicise, for the obvious reasons.
Yeah, no, sorry, Glenn, I'm being a bit slow. Harkamel?
Well, so the national campaign is the Ask Angela campaign, and that's what you will see in pubs and in mainstream media. But within healthcare settings, I think firstly, you can use that word if it's safe and appropriate to do so and no one else can hear you. Secondly, all our staff in all our areas are trained to recognise signs of distress. And the first thing that we do in any setting, regardless if people are worried or not, we'll try and make sure that you have privacy, as you should do, to discuss any concerns that you have when you're in a healthcare setting. And it would be at that point that members of the public are encouraged to share, or members of staff will ask if they spot any signs for any additional information. But that isn't if people are worried, patients should always have access to privacy and the space to discuss any of their concerns, no matter what it relates to. So it's just to remind patients that that is what they can expect and that isn't unusual.
Yeah, no, absolutely. I'd make another point just before we conclude. If you are the subject of domestic violence, never feel it's your fault. It's never your fault if you're the victim, and reach out for help, and we're here to help you. Ladies and gentlemen, hopefully you found today's annual general meeting and the presentation and discussions, as well as the celebration of the Going the Extra Mile award winners, a interesting session. Thank you again, everyone, for your commitment to the work we do, and to our frontline teams. Thank you very, very much for your day in, day out commitment to give the very best that we can to the citizens of Warwickshire. Take care, everyone, and I look forward to seeing you soon. Bye-bye.